Good morning. My name is Silke Gillessen, and I'm a medical oncologist from Switzerland. Jill asked me to discuss our paper that was recently published in the Lancet Oncology. It's one of the arms from STAMPEDE, Arm K, where we added metformin to standard of care versus standard of care alone. As probably most of you know, androgen deprivation therapy is the standard of care in advanced prostate cancer, but it has also metabolic side effects, and we learn more and more about them, especially also in the combination with DRPs. There are a lot of studies that suggest that metformin has anti-cancer activity in different malignancies and also prostate cancer. And our aim was in reality to see if metformin can increase overall survival. So that was the primary endpoint. But we also hope that metformin may be able to mitigate adverse metabolic effects induced by ADT. When we planned the trial, we again were, as always in STAMPEDE, really decided to have overall survival as the primary endpoint. And we assumed at that time, many years ago, a median overall survival of 54 months. I think that's important to know. And we wanted to see a 20% difference in overall survival. Actually, we would also have been gone for 10% because metformin, as you know, is a very cheap drug, and it's easily available, and also it's very well known, so we know the side effects, and the side effects in most patients are not severe. So, of course, you could have thought about the hazard ratio of 0.9 and 1.8, but for that, you would have needed a lot of patients. So with 20% difference in overall survival, our planned sample size was 1,800 patients. And one of the things that's important, we had 7 subgroups pre-specified for the final analysis. The randomization was straightforward, so we randomized 1,874 patients, 1-to-1. And as always in STAMPEDE, it was quite pragmatic, so all patients with metastatic hormone-sensitive prostate cancer could be included, but they had to be non-diabetic, so no treatment for diabetes, HbA1c less than 48 millimoles, or less than 6.5%. So that was the important inclusion criteria. We excluded, of course, patients with renal insufficiency, but this was in the end very pragmatic study population. And the patients were randomized again 1-to-1 to standard of care versus standard of care plus metformin. We started with 850 once daily, and then if patients tolerated that dose well, we went to twice 850 milligrams. Again, as you know, primary endpoint was overall survival. And as always in STAMPEDE, we had the vast majority of patients with de novo disease, 94%. And since this was a trial that was started a lot of years ago, most patients received ADT plus docetaxel, 83%, and only very few, 3% of the patients, had ADT plus an RP. And since we're talking afterwards about it, about half of the patients had low volume disease and the other half high volume disease. So the primary endpoint was not met, so the study did not meet a difference of 20%. The hazard ratio was 0.91 with a median follow-up of 60 months. The median overall survival in the standard of care arm was 63 months, so much higher, and that's a good sign. Our patients live longer for the patients on standard of care, and 69 months in the metformin arm. And if you looked at the 7 pre-specified subgroups, there was no clear difference in the subgroups. But interestingly, what we saw is that the OS in the low volume patients, there was really no difference at all. The hazard ratio was 1, whereas in the high volume patients, the hazard ratio was 0.79. And again, this was a pre-specified subgroup, but it was not powered, and we hadn't said or defined that we would think that the high volume had more benefit from metformin. So this is hypothesis generating, but it's quite interesting because we saw the same or the similar patterns also for PFS and for metastatic progression-free survival and for prostate cancer-specific survival. So interesting, and we will try to look much further into this phenomenon if we find maybe molecular markers helping us to define who might be the patients who benefit from metformin. Interestingly, a secondary endpoint, as we said, we had the effect on metabolic effects, and we saw that patients on metformin gained less weight than the patients on the standard of care arm. So patients on the standard of care arm gained approximately 4.5 kilos, whereas the patients with metformin only 2 kilos. And there was also benefit for glucose values, HbA1c, all statistically significant, and also total cholesterol and LDL cholesterol. The safety was as we expected. So we saw more GI side effects in the metformin arm for all grades, 86% versus 67%. And we saw also more renal and urinary grade 1 and grade 2 side effects in the metformin arm. So if you look at everything, there is no clear evidence that adding metformin to standard of care increases overall survival in unselected patients, in the overall patients. What was the primary endpoint in our study? We found some evidence of benefit for outcomes in the, as I said, pre-specified but not pre-powered subgroup with high volume, where we want to really go further and that requires really further evaluation and see if we find molecular markers maybe. Most metabolic parameters improved significantly, and that was irrespective of disease volume. And now it would be, of course, very interesting to see what happens in patients who receive the current standard of care with ADT and NRP, where we know that these patients have more metabolic side effects. And I'm really interested to see what other people think about the data. I'm of course biased because this was a trial we did because we thought metformin as a very cheap drug, readily available in a lot of countries, could help treat patients with prostate cancer all over the world, also in countries where there is not as much money they sometimes don't have access to ARPs. So now the OS was not different in the overall population, but I think it would be interesting to understand what people think about the data and how they will interpret it in their clinical practice. So with that, I wanted to end and thank Jill for this opportunity to present this study, and I hope I get some feedback from all of you. Thank you very much.